Hello and welcome to the third webinar organized by SAJIDA Health's Mental Health Program. And today's topic is physical and mental health. And the media partner for this webinar is Dhaka Tribune. And before I go on to introduce our esteemed speakers, I'd like to say a bit about what we mean by physical and mental health and what this topic is all about. So according to a World Health Organization, health is defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. We often tend to think of our mind and body as separate, but physical health and mental health are more closely linked than we realize. From the definition, we can see that no health is complete without mental health, which is the current motto of WHO. And I'm sure a lot of us feel that when we are mentally drained and we're upset, it somehow manifests into our physical well-being as well. So mental and physical health are equally important components of overall health. There are multiple associations between mental health and chronic physical conditions that significantly impact people's quality of life, demands on healthcare, and generate consequences to society. Similarly, the presence of chronic physical conditions can increase the risk for poor mental health. Nearly 1 in 3 people with a long-term physical health condition also has a mental health problem, most often depression or anxiety. It has also been seen that the social determinants of health impact both chronic physical health conditions and mental health equally. We mostly prioritize our physical health more often, and we ignore our mental health needs. But physical health and mental health really go hand in hand. Understanding the links between mind and body is the first step in developing strategies to reduce the incidence of coexisting conditions and support those already living with mental illnesses and chronic physical conditions. So without further ado, I'd like to introduce our guests so that we can begin this webinar and we can start our conversations. With us today, we have Dr. Abhi Shetty. He's the consultant liaison psychiatrist of National Health Service UK. Dr. Shetty, I welcome you to today's webinar. I hope you're well.
Thank you for inviting me. It's a pleasure to be here. I'm okay. How are you doing?
I'm doing good. I'm looking forward to today's discussion. And it's a weekend for us, so I've had a restful day. So physically and mentally at the moment, I'm pretty okay.
Very good. I've just had a baby, so I'm exhausted.
Oh, yeah. I know all about that. I have a 2-year-old, so I know it's not too distant a memory, you know, living life with a small baby. Those are long hours. We also have with us Dr. Mohammad Tariqul Islam. He's the director of SAJIDA Hospital. He's a doctor by profession with 33 years working experience in managing, providing technical support to hospitals, medical colleges, nursing, or medical technology institutes. Dr. Mohammad Tariqul Islam, welcome to our webinar. Assalamu alaikum.
Wa alaikum assalam. Thank you very much for inviting me.
We're looking forward to having conversations with you. Let me go on to our next guest, Dr. Harun Rashid, General Practitioner and Coordinator, ELFT BD Global Health Link Program. Dr. Rashid, thank you for joining us today.
Thank you so much for allowing me to be present. Just a clarification, ELFT means East London Foundation Trust, which is based in Tower Hamlets, East London. So we have a global health program, and I lead on the sort of Bangladesh sort of link program.
Thank you for that clarification. We also have with us Dr. Ashik Salim. He's the head of SAJIDA Mental Health Program. Dr. Salim, again, welcome. And thank you for joining us. I'd like to
Hi, Shreya.
Hi.
Glad to be. My line is glitching a bit.
Yeah, you're stalling a bit, it seems.
But it's a pleasure to be. Yeah, I think yeah, it's a pleasure to be here. I think you continue. I'll rejoin.
Okay, sounds good. Dr. Ashik Salim is also the Managing Director and Lead Psychiatrist of Psychological Health and Wellness Clinic, that is PHWC, and I hope he's able to join us with a better internet connection. I'd like to just start off our discussion. Some people who have joined us today may have a question about what does a liaison between physical and mental health, or the person who liaises between these two arenas of health, what do they do? How does this interface work? And how this particular issue is being addressed in the UK's health sector. So I'd like to throw this question at, or ask Dr. Abhi Shetty to give his opinion on this.
Okay, thank you. I think we all sort of instinctively understand that physical and mental health are related, but we sort of often forget about it. So, for example, if we are sad, we become tearful. There's a physical response to an emotional event. And similarly, say if we stub a toe, it's painful, and we become annoyed or angry. So there's an emotional response to something which is physical. So, these are just your day-to-day examples of how what happens to the mind is expressed in the body, and what happens to the body is expressed in the mind. And as you said, Sriya, unfortunately, when we deliver services, when we deliver healthcare, we sort of treat them as if they're two separate things. So we have hospitals for physical health, and then hospitals or clinics for mental health. What liaison psychiatry tries to do, it tries to bridge this gap. So I can speak about how it is done in the UK. As a liaison psychiatrist, I work in a team of mainly nurses, but also social workers, support workers, and some teams have also have other professionals like psychologists and occupational therapists. So just to simplify things, we deal with 5 Ds: distress, depression, deliberate self-harm, although we don't like to use the word deliberate anymore, so self-harm, delirium or acute confusional state, and drugs and drink problems. Okay, so these are the 5 sort of main conditions we try and help our medical and surgical colleagues to deal with. And we are based within sort of the emergency department. So I don't know how it is called, what's called in Bangladesh. Here we call it emergency department or casualty department. So in the UK, in most hospitals, there is a 24/7 presence of liaison psychiatry nurses in emergency department. And then we also work in inpatient areas within the general hospital. Just to give an example, say somebody has a heart attack, right? And they recover from the heart attack. Now, heart attack is those who have experienced it. It's quite a scary event. You could have died, but you survived. But then it leaves you feeling anxious that you might have another one. So that anxiety will then provoke a physical response. So we know that when we are feeling scared, our muscles become tense. So tense chest muscles become painful, or you might become your heart beats very fast and loudly. So you get palpitations, a very loud heartbeat. And if you've had a heart attack and you become anxious and you have these physical responses, you then might misinterpret as you having another heart attack, So you might call the ambulance and go to the hospital. And in the hospital, they do the tests, and your ECG is normal, but you still have the chest pain, or your heart is really beating fast. Okay, that's when we can help to sort of try and speak to the patient and find out, what is causing them to feel anxious. Another example would be, say, somebody has diabetes. Now, as you said, Shreya, in your introduction, anybody who has a chronic physical health condition, they are more likely to have a mental health condition as well. Okay, so and diabetes and depression are very, very strongly associated. And you might know that the treatment for diabetes is very straightforward. If you're insulin dependent, you take your insulin. If you're sort of type 2 diabetes, then you have to manage your diet and exercise. But complication rates in diabetes is very high, and that's because the emotional side is not looked after, and hence patients don't look after themselves because they are depressed or anxious, or they're feeling life is not worth living, right? And again, when patients come to hospital with complications of diabetes, if the diabetologists are aware that there is a mental health component to this, they can refer the patient to us. We then deal with the anxiety or depression, and if the depression is treated, the diabetes is much better managed. And a sort of third example would be, say somebody has so especially an elderly person, they come with a fracture of the hip, and they get an operation to repair the fracture. But then after the operation, they become very confused, they become very agitated, they might sort of scream and shout or hit out at people. And that's what we call delirium or acute confusion state. And again, we can, when they're referred, we then go and speak to the patient, make a diagnosis, and then, give medications to calm the patient down, but also see if there is any infection, or if the patient is in severe pain, and treat that as well. And that then helps the patient feel calmer, as well as recover from the operation and the hip fracture quicker. So just 3 examples to illustrate the kind of things we do in a general hospital setting, both in an emergency department as well as in patient wards.
Those are very, whatever you have said so far as a lay person who's not, a medical expert of any sort, they are so relatable, because I have had very close and still have very close family members dealing with diabetes, or even also other issues. Just the other day, one of my colleagues messaged me because my father passed away from cancer, and he messaged me asking whether we have mental health support for cancer patients, because it's such a big toll on the patient and also on the entire family. So I completely understand how important this is, this kind of having working this going hand in hand, and also having someone who does this work, or having a department who does this work. Because to be very honest, I don't think this is please correct me if I'm wrong, but this is it's not a trend in Bangladesh to have such services available. So we usually go into hospitals or medical facilities and get physical cures or solutions, but a lot of these conditions need the mental health support as well. So this is indeed for me as a topic that's very close to my heart. So I'll just, instead of me yapping about, I'll just go on to our next discussion point, because we usually have very limited time and we want to cover a lot of topics. So I'll just go on to Dr. Tariqul Islam, and I'll ask you if, I just said as a layperson what I have kind of witnessed or I have experienced in hospitals, but I'd like to take your kind of opinion and hear from you about the scope of mental health in the general hospitals and in general health. And according to statistics, approximately 30% of patients are present with mental health symptoms. And how are these being addressed in the hospitals? And what are the different types of treatments or procedures, if any, are there that are given if such cases arise? And as Dr. Chetty said, somebody arrives with a physical ailment, but that is impacting them a lot mentally as well. What kind of treatments are there to be given, or what usually is the protocol? Dr. Tariqul Islam.
Thank you, Shreya. You have already mentioned the WHO definition of health, and it actually mentioned that it is not just a physical health, it is a complete well-being of physical, mental, and social issues. And we found in most of the cases we giving more focus on physical health and ignoring mental health. For addressing the health issues, we need to address all components with equal importance and ensure coordination between physical and mental health practitioners. As Dr. Avi Sethi mentioned, which is practiced in UK, but I think in Bangladesh we are facing a lot of limitation in this. According to WHO, suicide is the second leading cause of death among 15 to 29 years olds, and people with severe mental health condition die prematurely due to lack of openness and inability to address the mental trauma. Besides, people with mental health, conditions often experience severe human rights violation, discrimination, and stigma. And awareness on mental health need to be increased for better understanding and reduce discrimination and stigma. At present, our general health hospitals, as I am working in general health hospital for more than 18 years, I found it's a lot of gaps, limitations, have limited scope of addressing managing mental health. We found huge gaps, like availability of mental health specialists such as psychiatrists, psychologists, counselor at our health facilities. In some places, especially in medical colleges, it is mandatory to have a psychiatrist. And in such medical college hospitals, you may have a psychiatrist, especially in Dhaka and big cities. But it is very difficult to find in other places in Bangladesh. And we also find lack of coordination between mental and physical health practitioners missing, and also we see missing opportunity among patients to share mental problems with attending clinicians. Actually, they are focusing mainly on physical health. As a result, missing the proper diagnosis and management, which is very important. So we need to address this with a strong advocacy to formulate policy to fulfill those gaps in our country situation. Thank you very much.
Thank you so much, Dr. Tariqul Islam, for your input. As you said, there seems to be a lack of such efforts. I'd like to go on and talk to Dr. Harun Rashid, but before that, I'd like just to tell whoever's watching this webinar that if you have for any of your own mental health need, you can call Shajon at +880-9678 771611, Kanpete Roy at 01985 275286, and SAJIDA Health Hotline at 09678 77151. And also, please, anyone, if you have any queries or any comments that you'd like to write or send us, please do so. We'll be reading them out within this entire webinar and also especially at the end of the discussion. I'd like to, ask Dr. Harun Rashid a few questions. That as a general practitioner, what would be the potential patient you receive with mental health issues, and what they do, and what are the procedures that are being followed in the UK, since you are, as you said, you are one of the people who represent, from Bangladesh, you're representing ELFT in BD. And also the other question is, can any of these measures or procedures be followed or adopted in Bangladesh according to you, in your opinion?
Thank you, Shreya. Are all the sort of viewers are Bangladeshi, or we have international viewers in this webinar? Shreya?
Sorry, Dr. Rashid, your volume or sound is a little low.
I can't even hear you today. I don't know. Is it my Wi-Fi or is it centrally? Can you hear me now?
It's a bit better. Maybe a pair of headphones would have helped, but can help sometimes.
I think maybe this is the iPad, isn't it? I'm not on my desktop. Let's see. I move a bit more near the Wi-Fi and see. Can you hear me now? Better?
Yeah. It's a bit better.
Maybe
yes. Go ahead. What was your query?
Put my light on. Okay, so I'll try to speak loudly as loud as I can. So,
yeah, that would be.
What I asked is, most of the listeners are the Bangladeshis in this.
Well, this is it is mostly Bangladeshis, but it is a platform that is online, so everyone is welcome to join in. So I know people have joined in from the US and other places as well. So
all right.
You can.
So I speak in English.
Yes.
So,
that would be wonderful.
Good afternoon. So basically, as a GP, I've been working in Tower Hamlets, which is in East London, for a good 28 years. And the local mental health trust, which is East London Foundation Trust, we work very closely. So primary care basically looks after the physical health, as all GPs are. And we work closely with our CMHT, Community Mental Health Trust, and, the ELFT Mental Health Trust in Tower Hamlets are divided into geographical wards. So we got 4 southwest, southeast, northwest, northeast ward, which are CMHT based, and it more or less sort of follows GPs in those boundaries. I'm just going to start. The NHS National Health Service Plan includes that's no mental health without physical health. Okay, that's in our 10-year plan, and we are a good few years into it. Even before the plan, GPs were actively involved in looking at the physical health of patients who are under the care of the East London Foundation Trust, CMHT, or even in community settings. We have a joint working relationship where once SMI, serious mentally ill patients, are discharged into community, or they are looked after in GP general practices, where a community psychiatrist nurse attends and does the review. So it's a primary care review which flows back and forth between the mental health trust and primary care. So patients who are much more stable doesn't need that intense input by the CMHT or even early intervention service or even home treatment team are looked after by GPs together with our primary care psychiatric nurse, and we review things. I mean, in few things I would say, which Dr. Sethi said, so there are quite a lot of people who suffer with long-term mental illness, are on long-term drugs, including antipsychotics, antidepressants, a mood stabilizer. There's some of the more recent antipsychotics like olanzapine, even, quetiapine and others have a strong affinity to cause metabolic syndrome, so making patients more susceptible to type 2 diabetes, including, if they have hypertension, they can affect their BMI changes. So we have to look at their physical health, yearly at least check up, their screening of their bloods, look at their blood pressure, look at, how they're managing their, HbA1c. Are they at risk of diabetes, or have they already become diabetes? Are they managing it? Mental illness also affects people's ability to look after their, physical health. So there's a lack of exercise, there's lack of eating the, nutritious food or healthy food. People get quite depressed and lose motivation. even being non-compliant with medication. So we work closely in terms of helping, and also sort of give a sort of heads up. If patients are deteriorating, we can sort of, it's a two-way traffic. We refer back to secondary care where patients, if they are showing any signs of deterioration or relapse, and they are also the other way around. Psychiatrists or the psychiatric team refers back to us, where people can be maintained on drugs, and we keep an eye on them. So it works together. So I think Bangladesh will be similar. The access is a very important issue. So we cannot compare here UK with Bangladesh. They don't have a registered GP where they can go and see their doctors free of cost. I mean, I know there are Upazila health centers and things like that, but I don't think Upazilas and even District General Hospital only have psychiatric mental health team. Outside the correct me if I'm wrong, Upazilas do not have any really direct connection. I know in Sylhet we went, and most of the Upazilas directly refer to the Osmani Medical College Psychiatry Department. So there is a huge issue of access based on people living urban-rural divide. Are people in urban areas? Are they living in sort of unregistered population who are moving in slums? Or so I think there is a great need if Shreya or Ashik will come, that we can help set up a template, a protocol where general medical officers in Bangladesh who can work together with their psychiatrist colleague in terms of sorting out the physical health needs of the population. And that one includes a lot of work, in my experience, in town hamlets, because as you know, Bangladeshis, we got a huge number of Bangladeshis in town hamlets. Almost 35% of the population are from Bangladesh. So the non-communicable NCDs are very high in Bangladeshis compared to the local population. Risk is high, diabetes is high, hypertension is high, cardiovascular diseases is high, and chronic kidney diseases are high. So we had some conversation with your team. Happy to help in setting up protocols, even having a pilot where we can see how general physician or doctors working in Bangladesh can work with their psychiatric team in looking at the health and well-being of their target population. And I know Bangladesh has more public-private combination, not like here. It's not all NHS. So happy to be involved. We had some discussion. We had a visit last year, and because of COVID, we haven't been able to make another visit. But I'm available to you if you need me. Thank you so much.
Thank you so much, Dr. Harun Rashid. I'd like to now, ask Dr. Salim to come and us and give you comments about this physical mental health, and also kind of given the understanding that as Dr. Harun Rashid said, that we require, or even Dr. Tariqul Islam was saying, that there's a lack of such services in Bangladesh, and what are the procedures that what's the potential there? What kind of procedures can be put in place, or how these services can be introduced? Dr. Salim.
Thanks, Shreya. Hopefully my connection is better now, and people can hear me. So I guess first I'd like to say it was great listening to Abby, and then listening to Tariqul Bhai and Harun Bhai, and thank you guys for giving this time to join our webinar. Abby and I trained as psychiatrists together. He was my senior by a year or so, and we kind of went through our junior training, SPR training, and then got consultant jobs. So it's wonderful to remain in contact and work together. Harun Bhai, we've been working, trying to build bridges between East London and our services in Bangladesh recently, and obviously Tariqul Bhai is with SAJIDA Foundation, and we're trying to demonstrate that we can provide care at standards which people do not expect. We think that when there is very little services, substandard services are accepted, but we at SAJIDA Foundation are trying to do things exemplary. So I think today's webinar is really interesting, and I think the next phase of questions, the next phase of discussions, I think we should have it towards towards action, because I think that's the motto of this of the mental health campaign this year. About what we can do. So I think going back to your question, is that that so in Bangladesh there are sporadic projects happening. So, for example, there's the MH-GAP project, which is focuses on giving mental health training to healthcare professionals in the government setting, and it's been done by WHO, especially in Cox's Bazar and in the Rohingya setting. The MH-GAP training happened to give mental health training to healthcare professionals, doctors, so that they're more aware and are able to provide the treatment. The plan and recommendations are that this should be done nationally. Unfortunately, it's an uphill battle. There's in general, in Bangladesh, most doctors, so if you do an MBBS degree, you will have done 2 weeks of psychiatry as an intern, and there will be a few questions. But from what I remember, obviously I did my MBBS a fairly long time ago, and I think we had 1 or 2 questions in our exam. So our experience to mental health and psychiatry is very limited. As a result, what happens is that a lot of the treatments that are given and a lot of the interventions that are given are actually based upon learning from peers or from someone's own interest. So there's a lot that can be done. And I think I will find it interesting to have some discussions about, especially from Dr. Harun, because he's visited us. He's worked in both settings, I guess similar to myself. We've worked in the UK, worked in Bangladesh. And we can think about how we can provide some services that will help to provide a more holistic kind of mental health interventions in the physical health setting, as well as providing better physical health to people with mental health problems. I think Dr. Harun Bhai, he had mentioned that people with a serious mental illness, for example, schizophrenia or bipolar disorder, just the act of having these illnesses actually put a larger burden on their physical health. And because they themselves can often be quite isolated, their physical health checkups don't happen often. The medications give them side effects for which they need follow-up and treatment. And if left to their own devices, obviously this doesn't happen. And even families, especially if they're not productive in the family, it tends to go into the back burner. So it's on both sides of that. How do we provide better mental health care to people who have physical health problems? And how do we provide better physical health care for people who have mental health problems? So it's both. It's about getting the interface on both sides of that. So I think those are my thoughts about how maybe we can spend the next 20 minutes just thinking about maybe some actions, some ideas about how we might be able to move forward. So those are my few thoughts.
Does anybody want to Dr. Shetty, do you want to jump in and add your comments on those? And there are also a few questions that what are how can we bring about an awareness among the general population about such integration? But even though this question has come up, I wondered that if the services are not in place, then is there a point to having awareness being built either? So I was also wondering about that. If I aware people, then they will expect a certain level of service and a certain level of somebody to be there to provide those.
You're absolutely right about increasing awareness, but not then providing a service. I mean, although UK has has invested a lot in services, it is still not enough. So I can imagine what the situation might be in country. I'm from India, so I know in India mental health is very much in the back burner. In the UK, I'm just talking about the liaison psychiatry services. So over the last 5 years, the NHS has invested heavily in liaison psychiatry service, and the main reason being this sort of pioneering study in Birmingham, which is a city in UK, which showed that if you invest £1 in liaison psychiatry, you will actually get back £4. Yeah. So in some ways, when you try to build a new service, you sort of think about the overheads, right? But if you sort of believe this study, then actually the investment you make into a liaison psychiatry service actually pays more than you actually invest, right? So that's in my view, a powerful message for your investors, whoever they are, because basically how it works is physical healthcare is expensive, right? And how a liaison psychiatry service will help is it will, number one, prevent unnecessary hospital admissions. If somebody comes to an emergency department and they get admitted unnecessarily, which could have been dealt by a liaison psychiatry service within the emergency department, okay? And number two, if somebody is admitted to hospital, then if there is a liaison psychiatry service, then they could be discharged quicker. Yeah. If without a service, they might end up in hospital for days or even months. And number three, particularly in the elderly population, and I don't know how the setting is. I imagine the family takes the burden of looking after older people, unlike in the UK. But in the UK context, older people who, after a hospital admission, are more likely to end up in a nursing home as opposed to their own home, right? And the liaison psychiatry service, if they are present, they then prevent that unnecessary nursing home placement, which is very expensive. So my sort of, I suppose, message to you guys is, use this study as maybe a precursor to your conversation to your investors, in that, if you invest in mental health service for general hospitals, it actually pays for itself and actually gives more than you actually invest.
Thank you for that. Dr. Tariqul Islam, would you like to add, comment on this, what Dr. Abu Shetty said? You're on mute, Dr. Islam.
I think there are a lot of differences in Bangladeshi context and in UK context. So our people mostly dependent on private services, not on public services, because you see we have lot of hospitals in from community level. There are community clinics, FWCs, that is in union level, then USC in Thana level or Upazila level, then district hospital, medical college hospital, specialized hospital in the division in the city. So lot of structures in our country, but in some way mental health is some form, it is ignored by some way. There are, I think, two things is very important. One is investment by the government or private sector. Private sector always thinking about profit, so it is difficult for them to introduce mental health everywhere because of getting patients, and it has a lot of cost. You see, it is a comprehensive type of management. It is not just to give a paracetamol and just cure the fever or pain. It has a lot of issues. We need to consider. It has psychotherapy, it has medicine, it has hospitalization. Sometimes support group can help. There are some self-help plan, there are some peer support, there is some follow-up plan, community level linkages, community support. Lot of things are actually related to mental health, and it is not just a psychiatrist responsibility. It is a responsibility of psychiatrist, it is a responsibility of a psychologist, clinical psychologist and counselor, and it needs a special setting. It's not just a outdoor facility, people come and go. No, it needs time to handle a patient in a private setting, and we need to change some phrases like mental health. It always has some stigma. Psychiatry or psychology, it always has some stigma. We can think differently, and we can create opportunity and access to the patients to prepare our facility with the team, with the room, with the lot of issues are there, like privacy and other things, and how they are coming to the doctor and they go out from the hospital. And we also need to combine physical and mental health, because you see, we cannot, every disease is interrelated with physical and mental health. You see, a mental health, it causes physical health because of neglect, because of torture, because of stigma, because of lack of care. So they are suffering from physical health. On the other hand, the physical health, it again, people suffer from mental health because of fear. Like you see, COVID this pandemic. Actually, we learn a lot from that. It also create a lot of mental issues that we could not address rightly, because even with physical health we could not address this rightly in right way, because of lot of other issues, a lot of protective issues and transmission of infection. So like a patient with cancer, actually depending on the prognostic issues, like if it is a deadly disease or it is a chronic disease with lot of sufferings like asthma, so it actually patient affected by mental issues, and we need to combine both physical and mental health practitioners to refer patients and to have the support from the team of mental health unit. Then we can help people. So in one hand we need to prepare our facility, and in other hand we need to aware our people so that people can come. So both sides we do side by side. Otherwise, it will not actually help to improve our mental health. Thank you.
Thank you so much. Before I move on with another question, I'd like to let all our viewers know that for any of your mental health need, you can call Shajun at +88096787716111, Kankite Roy at 01985275286, and Sajida's health hotline at 09678771511. So I'd like to ask this question again, bring this question around to Dr. Hanur Rashid again, that, in your experience, what are some of the scopes to integrate mental health, interventions in the physical health setting? And, also comment on the points that Dr. Tariqul Islam said and also Dr. Abhishetty said.
Thank you, Shreya. I think the basic thing that in Bangladesh context is, there are private psychiatrists, but I think, the majority of the population depend on the public health sector, especially, the poor and the middle class. So we need to have this Upazila Health and Family Planning Officer, Upazila Medical Officer, and others to be trained in general principles of psychiatric care. So they can, when they see patients, they can at least immediately diagnose, are there underlying mental health issues, are there, and they can at least give the first level of treatment, and then if that needs to be scaled up and referred. So I think we need to train the vast majority of Upazila health clinical officers, and that includes just not the doctors. I would include the nurse, and if possible at the community setting, the FWB, FWCs, to at least immediately able to sort of diagnose or find out who needs to intervention, and then they can be scaled up. Because to train psychiatrists and send them to Upazila is Bangladesh doesn't have that sort of physical ability, doesn't have that manpower or human resources, or it's a huge cost. So I think we should have generic medical officer who can deal with non-communicable diseases, including mental health. And then there are specialist centers who are available in district general hospitals, or maybe few Upazilas who bang up together and have a common mental health officer being posted. So we could have a team that works because even for areas like Sylhet, or to send someone from Upazila in Chatok all the way to Sunamganj, it's just impossible for people to travel when they're really ill, mentally ill, and need some intervention. So maybe, I don't know, a community intervention team, a CMH team, Ashik would know, some form of home treatment team type of thing, who will be generic but available on supra Upazila level, but between district general hospital as a sort of middle point, and can screen out patients who are more seriously ill and get the schizophrenia and the bipolars and the severe PDs up the scale. But those that can be dealt at the Upazila level should aim at. The other thing we could do, I'm suggesting to colleagues in Bangladesh, including Dr. Tariq and Nashi, that we could set up some sort of pilots or MDT type things, where a physical medical doctor can sit with the psychiatrist in once a month, like we have here, MDTs, where we look at the blood test results. I know a lot of patients who are antipsychotics needs regular ECGs, and things like that. So we can set up some pilots and give it to the Ministry of Health and Welfare, whether they can take up some of these. I know Bangladesh is working now on a mental health sort of plan under WHO, and I think we spoke in that last meeting. So we can feed into this and try to do that. And I think it's not too tough to screen out diabetics, the high cholesterol. We need to look at the liver functions, once a year, thing like that. So a lot of antipsychotics have adverse effect, including fatty liver disease. So I think on a health policy level, unless we have the government or the DGHS on board and their mental health director, who is in charge of NCD on mental health, an overarching mental health policy is needed for Bangladesh. It may not need that much because you got a lot of now SAJIDA, Bragg, and other people are doing a lot of outreach work, para counseling. So what I suggest that we set up something which is appropriate for Bangladesh, is affordable in Bangladesh.
Yes.
It looks at the cultural and needs of Bangladesh, because we can't have like for like. From the UK has a different setting, different culture, different resource allocation, and we can work. Similarly, psychiatrists may need some also updates, CPDs, because obviously they see most of the patients, they need about updates, what they need to look for physically, for their patients, how often they need to do their lipid profile, how often they need to do their HbA1c, and look at their liver function test and things. And so it can work together, but we must depend on mental health, because correct me, Ashik, there are only about 200 psychiatrists in the whole of Bangladesh for a population of 180 million. Am I correct?
Yeah.
Yeah, I mean, even if you invest for the next 5 years, you might be able to make 400. There's going to be nothing, looking at the divided by denominator 180 million. We'll have each psychiatrist looking after, it's just impossible. So I think let's work together. Let's set up a sort of MDTT, or at least a protocol where we look at physical and mental, and both sides needs to sort of train and teach and upscale some pilot, and this can be done. I hope so.
Yeah.
Dr. Salim, I'd like your take on this.
Thank you. I think that's really interesting, and after just while having this webinar, it makes me realize that why we haven't done this already. I mean, we SAJIDA Foundation, we have our hospital. We provided COVID care, one of the first hospitals that got set up, and now we were asked to set up a COVID hospital in Joshua, which we're still looking after. So we've got so much experience in running a hospital, but I don't know why we've never thought about doing a liaison service with there. We have a mental health setup, PHWC. We have Shajon, which is a tele mental health service, and it seems silly why we haven't done it yet. So I think after this call, we need to get in touch with Tariqul Bhai and myself, and then we need to get Abby on a plane to come over and help us set up a liaison service at the SAJIDA hospital. But I think we will have these conversations seriously later. But I think the way we can deal with this is one, through partnership. So like Harun Bhai said, there are people who are willing to help. So we just need to be able to ask the right people to be able to to give us training, resources. There are resources available, so but human resources we don't have. Finances are available, but for people to provide training. So for example, we at SAJIDA, we're looking to build a couple of mental health hospitals, and when that happens, we will need psychiatric nurses. Nursing as a specialty doesn't exist in Bangladesh. So there we will need partnership for people to provide us with this training so we can provide high level of care. Similarly, support workers, support staff, mental health social workers, nursing assistants. We will need a vast range of training, and hopefully through partnership we will be able to do that. So I think one way where we can at least try and address the issue is through partnership. The second way we can try and address the issue is through training, but not looking at training professionals, but training paraprofessionals, because we don't have the time to give people a master's or a PhD or a doctorate or a post-graduation for them to be able to do the work. What we need to do is we need to train paraprofessionals. I went and visited our mental health hospital recently, and it's overwhelmed with patients. There are 370 patients right now under 2 psychiatrists. and they're providing the best possible care that they can give. But and then I had this idea that if we had 50 paraprofessionals in there who we gave a 6-month training, they would be able to take the burden off the 2 psychiatrists, and to be able, all you need to do is just teach them how to do a mental state, and at least they can do the mental state every 2 or 3 days and provide that feedback through a pyramid structure up to the psychiatrists, so that the care can be provided. So there are ways. So I think through training of paraprofessionals, whatever we call them, para counselors, paramedical staff, para whatever, or lay professionals, by doing that, and secondly, by making partnerships, so that we can, we can learn from each other, and hopefully have services which provide a good standard of care.
Thank you for those remarks. In fact, I was wondering, I think it has been touched upon a bit, but if anybody wants to take this, that I had 2 questions myself. One is, given the entire COVID scenario, I mean, this must have impacted this need for mental health support for people with physical ailments to a different level, right? Because COVID has taken people's anxieties and everything off the charts. Also, with a lot of requirement of bereavement counseling, which I do not believe is something that's very rampant in Bangladesh. So if anybody would want to comment on that, or even Dr. Shetty, if has your experience during this COVID shifted, or how has it shifted or changed or during this time? The other question I had is this, when a person, say, with family dealing with diseases, that is, be it diabetes or be it something much more serious, or life-threatening in the sense like cancer, as it is in a country like Bangladesh, where the socioeconomically patients come with very little they may not have a lot of financial assistance, or be able to afford a lot. So what kind of, in such a scenario, giving a patient physical treatment in itself can be a financial burden. So how would they deal with also requiring some mental health support, or, would any of your comments be on that? These were my 2 questions. Dr. Shetty, you can start.
So shall I answer the COVID question? So we've seen an increase in patients with mental health problems during the pandemic. Early on in the pandemic, we saw what we call psychosis. So patients who have lost contact with reality, they were hearing voices or seeing things or believing in things which weren't true. And this is a well-known phenomena. So pandemics are associated with increase in psychosis. And often the good news is that this psychosis is, although it starts very quickly, it gets better very quickly as well, even often without treatment. Just the fact that they get admitted to hospital, they get receive sort of supportive care is often enough. Sometimes they might need a low dose of an antipsychotic, but for a short period. So that's one impact. The other impact is, as you said, bereavement, and also post-traumatic stress. So COVID has resulted in a lot of ITU admissions, intensive care units. And intensive care units are very scary environments. And when you're discharged from ITU, you are left with sort of painful, traumatic memories of the care you receive. So that has resulted in additional sort of referrals to psychiatry services. And thirdly, the societal impact. People have lost jobs, people have lost relatives and friends. People are scared. They sort of they feel that, especially if the government or the society or the community haven't come to support them, then that has a mental health impact. And we have seen an increase in self-harm and suicide rates in the UK. So a physical infection has a huge mental health impact.
Yeah.
Thank you for that. I think our time is almost up. We just have 1 minute. just wanted to hear from anyone else has any closing remarks that you'd like to share before which we could end. Dr. Salim, Dr. Taikul Islam, Dr. Harun Rashid, Dr. Shetty, please.
Yeah, thank you. I think I should. Yeah, thank you. I think. Yeah. What actually our Ashik Bhai said, I think we can start a dialogue between us, and we just can set up a mental counseling unit or room to provide psychological support, and also linkage between our physical our clinicians with our PHWC, like Ashik Bhai can orient, or we can arrange some sessions to orient our physical clinicians how to deal with mental issues. And we can also set that what Harun Bhai said, that we can pilot something, and with some investment we can do some pilot in our SAJIDA hospital. We have a lot of experience, especially in COVID, and what Dr. Shetty said, COVID actually give us a lot of pressure on our mental side, and we found many people, and we also interviewed a lot of people post-COVID. And they suffered a lot of mental issues, and also our call center from mental health, from physical health, they support on that. So we need to do something in SAJIDA first, and we can see the result jointly with our PWSC and hospital and PWSC. We can do something different in Bangladesh. Thank you.
Thank you for that. I believe that it's now time for us to end this today's webinar. It's very apparent from today's discussion how important it is for mental and physical health both to be taken care of equally, and how one impacts the other. So after today's discussion, it's also great to hear about the proposed pilot projects which may be started, the affiliations which may be started, and I'm sure we all look forward to that day. So I hope everybody has a good rest of the weekend, and we look forward to the next webinar that will be hosted by SAJIDA's mental health program. Thank you to our esteemed speakers for their time, and good evening.
Thank you.
Thank you.
Thank you.